So my name is Katie Bucher. I'm the marketing specialist here at Providence Little Company of Mary. And on behalf of marketing, I just want to welcome you to this evening's presentation. I'm going to go ahead and introduce our moderator for this evening, Nancy Collins. Nancy is an oncology nurse for over 33 years in the South Bay and has worked as a nurse navigator for Providence Little Company of Mary Women's Imaging Center for the past 6 years. She has extensive experience in community education and nursing management and was instrumental in the establishment of our cancer treatment program in the early 90s. Today, Nancy spends time with newly diagnosed cancer patients and their families to answer questions and explain medical options. She also schedules necessary appointments with specialists, often streamlining the diagnosis to treatment process in order to shorten the time spent waiting for care. So please help me in welcoming Nancy.
Thanks, Katie. Hi, everyone. Good to see you tonight. I hope you have a great time. I know the first part of it is screening, and that's always kind of scary with the dermascan, but we all need it. You know, we got to face it. The fact is that summer is upon us, right? So those of us that are lucky enough to live in Southern California know that this is going to be an amazing time of the year, long days, perfect temperature, no humidity, very few bugs, but a lot of time outside. And I'm guessing you're like me, that our favorite things to do are outside, you know, playing with your grandkids and hiking and riding bikes and walking and just enjoying the outdoors. So it's important that we take a little precaution tonight and listen to Dr. Kwan and what she's got to share with us so that we know how to best protect ourselves. As all of you know, skin cancer is really the most common kind of cancer that we deal with in this country. And it's no surprise that we really encourage you as healthcare providers, and as an oncology nurse of 35 years, we find it early, we treat it early, and we get rid of it before it becomes a problem. So that's really our MO here, is just learn about it and understand it and then nip it in the bud before it becomes something that becomes more complicated. But the trick about skin cancer is it looks like a little freckle or a blip or a nothing. And so I was just talking to some wonderful people here tonight about the fact that the best thing you can have as a skin cancer screener is a partner who looks at you and sees you and can give you some feedback on that funny looking thing that's on your shoulder and you haven't taken care of it yet. So let's be mindful of that. Know your body. Even in breast cancer, which is my field right now, just know our bodies. We know our bodies better than anyone. So if you see something funny, just get it checked out. Most times they can get rid of it and it doesn't ever become anything more than that. Anyway, it's a pleasure to have you here, and I'm really happy to get to introduce Dr. Kwan. She's an amazing physician and busier than can be, so we're really lucky to have her tonight. Dr. Kwan was born and raised in Southern California. She recently returned home to the South Bay after 11 years in the Navy. She served as a general medical officer in an amphibious warship, accompanying it from New Orleans through the Panama Canal to its home port in San Diego. She also served as a staff dermatologist in Pearl Harbor for 4 years. Dr. Kwan attended medical school in New York. Her main focus is medical dermatology, where she feels she can best help patients manage their skin conditions. She's a fellow of the American Academy of Dermatology, and Dr. Kwan also has a strong interest in academics. She has published more than a dozen articles in peer-reviewed journals in the fields of dermatology, orthopedics, physician medicine, rehabilitation, and trauma surgery. In her spare time, Dr. Kwan enjoys photography, cooking, hiking, and spending time with her husband and daughter. Sounds like a fun gal to be around. Anyway, please welcome Dr. Kwan.
This.
Okay,
you're good. Okay, so clicker. Let me figure out I can use this clicker. Let's see. This way? Okay. All right. right, so I'm Dr. Kwan. We're going to be talking about the sun in your skin and how to prevent and detect skin cancer. Okay, so let's just talk about, the structure of the skin. There are three main components. We have the epidermis, which is that layer that kind of exfoliates off, and then the dermis, that's where all your collagen and elastin is. It gives the structure to the skin, and then of course the fat underneath. And this is just a microscopic view of the same thing, but basically you have your epidermis, that purple stuff, the dermis, all the pink stuff, and below it is the fat. And it takes about 2 weeks for the skin to mature up from this little layer right here, which I guess it's not showing up too well with this pointer, but from the bottom up, it takes about that time. So let's talk about the sun, which there's a lot of in Southern California, clearly. So two things that we'll talk about. Mostly we'll focus on skin cancer and precancerous lesions, but also, a little fun stuff about photoaging and some interesting photos I'll have at the end. Okay, so the sun, composed of many different wavelengths, including gamma rays, X-rays, ultraviolet, which is what we're going to focus on, visible light, that's the red, yellow, green, blue, purple that everyone sees, infrared, microwaves, and radio. The only part you can see, obviously, is visible light. Everything else is invisible, so keep that in mind. And even on cloudy days, it's there, so I have to tell people, just make sure you have your sunscreen on every day. Just because it doesn't look sunny doesn't mean there isn't UV light, which can damage your skin. Okay, so in terms of UV light, there are three components. There's UVA, UVB, and UVC. Don't worry too much about UVC. It's usually stopped by the ozone layer. UVA is the aging, A for aging rays. It's associated with wrinkles, but also skin cancer. Melanoma is highly associated with that. It does penetrate untreated window glass. So if you have window film on there that blocks it, you have more filtering of that out, but regular window glass like your office window, your car window, they don't filter out any of the UVA. UVB is your B for burning rays. It's the one that's more responsible for regular basal cell, squamous cell, the more common types of skin cancer. It's the one that when you have your SPF, sun protection factor in your lotions, usually referring to how much it's filtering out of that UVB ray. There's some, filtering out of UVB through windows, but it has to be a certain thickness. It's there all day, but obviously more common during about like 9 to 4 or so. And just kind of another depiction of where these rays penetrate. So that is a picture of the skin. You'll see that UVA penetrates the deepest. UVB just kind of mostly goes up to the top layer of the skin, your epidermis, and UVC doesn't even hit there. So how can sunlight cause skin cancer? So the sun will have UV rays, which you can't see. It hits the DNA, and it causes changes in those. If you get enough changes, you can get the cells to divide faster. And if you divide uncontrollably, you get a tumor, and that can be cancerous. Just another, again, depiction of, this is normal, healthy skin, where we see organized collagen in the dermis, and elastin. It looks like normal structure. When you get UV damage, you get enzymes that are produced in the dermis that disorganize them. You get UVB hitting and causing changes in the DNA in the epidermis, and these cause structural damage to your dermis as well as epidermis. So what does UV actually do in terms of practically, what can you see? Short term, you get the sunburn, a little bit of redness. Long term, it causes remodeling of the skin that causes your photoaging. Those are your wrinkles, your sagging spots in your skin, the pigmentation, all those vessels that people get. And a kind of dramatic picture here where you see the sun protected areas and then not sun protected. And this is a truck driver who always drove with his left side, obviously, to the window, and you can see it's dramatically more wrinkly than the other side. Yeah. So in terms of skin cancer and precancerous lesions, we have a few items. Your precancerous spots are your actinic keratoses. Those are usually scaly spots that aren't skin cancer, and they can vary as to, whether they can turn into a skin cancer. It depends on how thick they are, how many you have of them, how long they've been there. We'll elaborate more on that. And then your skin cancer, the most common type, basal cell. Second most common type, squamous cell. Those don't look like moles. and melanoma, which usually looks like a funny mole, but sometimes can actually be not colored either. Okay, so let's talk about a few cases. So we have the 62-year-old gentleman who comes in with this lesion on his cheek. It's been there for about 6 months. It's gotten bigger, it doesn't bother him, but it's not going away. He spent a lot of time in the sun, he has very fair skin, but he's never had skin cancer yet. And we see this red, bump, papule, has some vessels on it, it's very shiny. So we need to shave biopsy it. This is what we usually use to biopsy things. It's like a flexible Gillette razor. And we basically numb up the skin with local anesthesia, and then we pinch the skin a little bit and then shave off the top. We don't need to get all of it because most skin cancers are relatively superficial, so we don't have to dig very deep to get a sample, and that will confirm the diagnosis. So this is his skin on the left and normal skin on the right. You can clearly see there's something growing here. And that's a basal cell. Most common type of skin cancer. Many cases per year in the US, and there's an increase over the last decade, with the greatest increase in women actually. Slow growing, it usually doesn't go anywhere, so even if it's been there for a few years, it's highly curable, mostly found on the face, neck, other sun-exposed sites. Risk factors: fair skin, being out there a lot in the sun. Sometimes if you've had radiation, areas of damage can be more susceptible to this kind of skin cancer. If you have lowered immunity, like you're a transplant patient on immunosuppressant medication, you can also be higher risk for basal cell. And then there's some strange genetic conditions that also increase your skin cancer risk for this. And in terms of classifying skin types, we do usually go 1 through 6. The fairer skin types are the 1 through 3. Usually those people don't tan a whole lot, they burn more. And then 4 through 6 usually will tan well and not burn a whole lot. Okay, so basal cell has many different looks, and we'll go through each one of them, but it doesn't always look the same. There are some common factors that I'll mention, which usually they're kind of shiny. There are some vessels if you look really closely, and sometimes the borders can be rolled. So they're kind of raised up on the side. So the most common type would be your nodular type. It has that rolled kind of border, a little bit of vessels that you can see on top, very shiny looking. It doesn't look like it belongs there, and it's usually on the head and neck. Superficial basal cell, this one can be tricky because it often just looks like, sometimes it looks like eczema. And it just looks shiny, there's some vessels on it. If you use a little alcohol swab, you can kind of see it, bring out some of the vessels in it. Some people who make this make like 10 or 15 of them. So, there does, I think, tend to be a genetic component to some of these. And you see this a lot in younger people. Your classic basal cell, ulcerated in the center, so all eaten up, raised border, lots of vessels. And then your pigmented one, some people are like, I think this is melanoma, but if you actually look really closely, you'll see these vessels here, and it's kind of shiny, and this coloration is just part of the skin cancer itself, but not the cause of it. You have ones that look like scars. You're like, oh, okay, what's this? It looks like a scar, but I don't remember having anything there. They're usually very firm. They can be a little more aggressive, but generally they do have kind of this, like, some vessels and a little bit of a rolled, shiny border as well. So how do we treat it? Surgically and non-surgical options, depending on what kind it is. Curettage and electrodesiccation is just basically scrape and burn. That is usually for superficial or very focal lesions of basal cell. We use something called a curette after we numb it up. And basal cell has a different texture than normal skin, so when you scrape it, it feels kind of like gelatin, so it scrapes off very easily, and normal skin doesn't usually react that way. So you scrape it, and then you cauterize it, and you scrape it again until you're sure that you've gotten like the right texture of the skin, it's firm, no more gelatin type of basal cell. And then our obvious excision usually takes some margins around it if we do it that way. Usually looks like a football shape. People are often ask me, why is it such a small spot? Why is my scar so big? Well, the reason is, you have this spot and then you take a margin around it, and you can't take a circle and actually like close it, and you'd have two ends sticking up. So you end up having to take these little triangles, which happen to be about the same width as the actual excision site. So then you end up having a scar that's like 3 times the length of the actual site, and that's just for practical reasons. Mohs, I'm sure people have heard of. It's a specialized technique for removing skin cancer, usually in difficult to remove locations or high-priced real estate like the face, head, neck, that kind of thing. Larger lesions, ones that you have difficulty closing, where you're trying to conserve tissue. It was a technique created by a doctor called Frederick Mohs, and it's basically a staged surgical removal of a skin cancer. So what they do is they will see it, they'll take a little circle, take a piece of it, and then they mark it into quadrants. They examine it under a microscope with a special processing technique that they can do right then and there. They have a special lab that does that. And then they can say, oh, there's a little bit left at this little corner. So let's just take a little bit from this side instead of going all the way around again and taking a bigger spot. So in that way, they can determine that, hey, everything is clear, and after everything is clear, they close it up. The defect is smaller, and you have a smaller scar overall. We talked about the reasons. Location is usually the main reason, but something that's aggressive, something that you can't really tell like where the start and end of it is, something that's come back, and I forgot the size too. Anything that's like really big, sometimes in a difficult to close location like the shin, can be also a Mohs candidate. Non-surgical treatment options are usually for superficial types of basal cells. So topical creams, imiquimod, Aldera, 5-fluorouracil, which is a topical chemo agent. These can also be used for precancerous spots as well as some other things like warts, but generally we reserve this for superficial basal cell. And this is a result of somebody using that. They have a skin cancer, they apply it there, and then after everything heals, they have very little scar of any kind. Sometimes when people are applying this, they get a little freaked out because they're like, oh my God, I'm getting a reaction beyond where the site was. That's actually very common because superficial basal cell is hard to determine, how far out it extends. And the other thing is that people who have this often have sun-damaged skin. And the medication often makes sun-damaged skin react as well, just not as intensely. Okay, so radiation, that's not used a lot for treatment of basal cell and squamous cell unless you're not a surgical candidate or you can't use the creams for whatever reason. So I kind of touched briefly on this earlier. Why didn't I just cut it out when I knew what it was? Well, sometimes you can be fooled. You like biopsy something, you think it's something, but it's like a precancerous spot. You wouldn't want to create a large scar in something that wasn't truly a skin cancer. And then on the occasion that you think something is basal cell and it turns to be like an amelanolic melanoma, you actually need a larger margin. So it's going to depend on what the actual sampling shows in the beginning. Okay, so just summary, basal cells grow very slowly. They don't go to other organs of the body. It has happened, but it takes a few decades if you leave it alone. And people who have basal cell obviously have a higher risk of developing more basal cells, squamous cells, probably melanoma as well because they have risk factors. And these people should be seen regularly for skin checks, at least once a year. Usually after the first year of the diagnosed basal cell, we'll see people every 6 months. And then after that, every year if nothing else shows up. Okay, so case 2 is related but different. This is the second most common type of skin cancer. Usually looks like this big angry bump with crusting somewhere on sun-exposed skin. And it can bleed. Sometimes they grow really fast. I've had some people like come in and say this has grown over like a week. That's a special type of this subtype. Usually same kind of risk factors, somebody who's got a lot of sun exposure, sometimes burns, but always tans. Sometimes you get like slightly darker skin types that get this as well, but mostly it's the lighter skin types. This guy works in landscaping, so that risk factor of being out there a lot clearly had a factor in this. So just a summary, nodule, red and angry looking with crusting in the center. So we biopsy it, and we get, this big kind of cotton candy looking thing in the center, which is the skin cancer. And that's a squamous cell. So this is the second most common type of skin cancer. Obviously, many cases per year in the US, has a greater increase in the last decade. Again, women for some reason, and sun-exposed areas. It is a little higher risk than basal cell, but I don't think I've really seen a lot of squamous cells metastasize unless they're in certain areas, like in the mouth, on the lips. That can be a higher risk because they're closer to the any lymph nodes. So we already talked about risk factors, but there are some people who get them in areas that never see the sun if they've had like some kind of chemical carcinogen exposure, not as common these days. They can look like different things, just like basal cell can look differently. They often are, growths that stick it out of the skin. They're not just shiny with vessels. They're often hard and scaly, and you can feel like there's something underneath the skin, like they're really just firm. And there may be like a little horn coming out of the skin as well. Examples, sometimes they look obvious, sometimes they don't. Treatment, really the same thing as basal cell. You can excise them, you can scrape and burn them if they're superficial, Mohs surgery if it's in a cosmetically sensitive location or difficult to close location or aggressive subtype. Radiation therapy, again, only for people who are poor surgical candidates, and then topical creams for those who are the more superficial types. And same thing, people need to be seen regularly after they have this kind of skin cancer because they're higher risk for developing other ones. This is a guy, this next case is a guy who's had squamous cell, but he has some rough red spots on his face, and he's worried that maybe they could be additional, squamous cells. But these are actually precancerous spots. Usually they're kind of gritty. You can feel them more than you can see them. They're they don't have to be necessarily red, but they just have this very sandpaper-like texture. Some of them are thicker, some of them are thinner. Sometimes you see them, they're very diffuse all over the face, scalp, arms, legs in some cases. There's not a high risk to malignant transformation. However, the thicker they are, the longer they've been there, the more you have, the higher the risk that one of them is going to become something. So generally we do treat them. And it's kind of on a spectrum, so we have photodamaged skin. Your next step is your actual, precancerous spot, the actinic keratosis, and then sometimes you get a superficial type of squamous cell that is called Bowen's disease, and then if it progresses and it can become invasive, deeper into the skin, you get like the actual full-on squamous cell. Usually it's funny because these actually sometimes hurt more than actual skin cancer. People often say that they sting and burn, or they hurt them, or they bleed. Sometimes it's actually more symptomatic than basal cell or squamous cell. And again, you can usually feel them more than you can see them. People like moisturize, or like the spot's not going away. I thought it was just dry skin, but it's not going away. Just some more examples. These kind of ill-defined, scaly, rough spots, usually in sun-exposed skin. So how do we treat them? The most common way is to use liquid nitrogen, which is a localized therapy. And it basically destroys, it gives frostbite to the spot. Now, if you have a lot of spots and it's like everywhere, it's kind of hard to like dunk the head in liquid nitrogen. So we use a topical therapy. I know this looks imposing, but that's just the way it's stored. Like such as Effudex or Aldera, Picado. Those are the things that we also use for some superficial basal cells as well as superficial squamous cells. There's also something called photodynamic therapy where they put a sensitizing agent on your skin. You sit there for like an hour and then they put you under this red light and it activates all of the precancerous cells and destroys them, but it makes you very sun sensitive. And when you're getting the treatment, you feel like your skin's on fire. So they usually give you like a fan to kind of cool yourself down. And this is a progression of, you can see, this person has some sun damage, they're putting on the cream, and they get red, and it kind of gets scaly, and afterwards it scabs over, and then they get much smoother skin. This is the photodynamic therapy. Usually it's this little like solution they put on, you have to incubate with it, and then they put you on this blue or red light, and then it activates, and you feel like, again, your face is really hot, and it destroys all of those precancerous spots. Okay, so again, these people should be seen regularly because people who have these have a higher risk of skin cancer if they haven't already had one. But if you find one that's changing in a way that just seems different, you're worried it's progressing to skin cancer, these people should come in sooner than their regular skin check. Okay, here's the scary one. It's very black. It's a younger person. It's been here for a few months, but it's not symptomatic. She's never had anything like this before. She's had a lot of sun exposure, even though she has no history of skin cancer. She uses tanning beds and sunbathe. Mom had some kind of non-melanoma skin cancer, but not melanoma. But you can guess what this is. So you see these really abnormal, ginormous cells in the epidermis. They have really big, nucleoli. They don't look normal. They're very bizarre looking. And this is a melanoma. This is the skin cancer everyone always worries about because it's the one that can, cause mortality. Of the 62,480 new cases in 2008, there were 8,420 deaths. So it's something that's very risky. The lifetime risk of melanoma has increased over time, probably because of people's habits of being in the sun and not having sun protection, whereas probably, the early 1900s, everyone was wearing a hat and, trying to keep their skin, not tan. The habits and the styles have changed over the years. But melanoma can affect all ages, but it's most common among younger women, age of 25 to 29. Of course, you do have some older people that have sun-damaged skin, and you can get this thing called Lentigo maligna, and that's usually someone who's very old, has a lot of sun exposure, and it's usually on the head. Anyways, so risk factors for melanoma, obviously increasing age because you have more sun exposure, fair skin. Redheads in particular are very prone to melanoma because they don't have the right kind of protection. Their pigment isn't protective. It's like a leaky umbrella sitting on top of their DNA and just letting all the, the UV damage their skin. People with lowered immunity can be more susceptible to melanoma, like heart transplant patients. Ultraviolet exposure, usually it doesn't have to be chronic, it just be these really horrible sunburns intermittently done in childhood, and those definitely increase your risk, and tanning bed use, of course. Usually they're not symptomatic, they just, they appear whether it's in a new mole or existing one, they just look different than the rest of the spots. And it doesn't have to be, A, B, C, D, E, it could just be the one that's different. So in terms of A, B, C, D, E, we always, harp on asymmetry, borders, color, and, something that's bigger than 6 millimeters and something that's changing. Of all of those, the only thing you should really be concerned about is the evolution, because I've seen melanoma that's less than 6 millimeters, tiny, and it's symmetrical, and it's all one color, and it's just really dark. And that's the main thing. It's just darker than the rest or different than the rest. There are some people who make funny moles, and all their moles look like that, though. But then they have one that just stands out as different from the rest of those, and that's usually the one that's concerning. And there are different subtypes. There's types that are very, typical, really, really black, but there are other ones that are kind of slightly different shades of a little brown, a little pink, and there's some that are not colored at all. One time I was treating this redheaded guy for precancers with, I think it was Affudex, a topical chemo agent, and there was one that just never went away. And I'm like, it must be a basal cell or squamous cell. Shaved it, amelanotic melanoma. So yeah, so if something doesn't respond to treatment, always come in. Okay, so melanoma does have high cure rates if you diagnose it and treat it early because it's going to be thinner and less aggressive, but it has a high potential to spread to other parts of the body if you don't treat it. And the prognosis depends on its size, location, and what kind of subtype. So it's really important if you see something that you're worried about to come in sooner. So these people that I see, they actually come in more frequently than every year. The first year, usually I see them every 4 months. And then after that, if nothing happens, every 6 months for 10 years. After 10 years, they can come every year. And anyone who has a first-degree relative that has it should be, checked. And then in between skin checks, anything that appears, they should come back earlier and have a look at it. Okay, so now that we talked about all the cancer stuff, let's talk about the things that people actually, also come in for that are not malignant, but obviously, people are concerned about. That is your photoaging. So chronological aging and photoaging are different. Chronological aging is if you hid in a cave and you never had sun exposure. It's the stuff that like on your buttock, breast area, double covered areas. Those areas have very little sun damage. It's genetic, skin type, and age related. Photoaging is aging that's accelerated by UV damage. And that leads to your lines, your deeper lines and wrinkles, your leathery skin, enlarged pores. So pores often enlarge, on the face as you get older because of sun damage. Fine vessels on the nose and cheeks, and then lots of pigmentation, whether that's these 4 items, which I'll show you pictures of. People come in for this type of stuff all the time, and they're like, they worry it's malignant, or they're more cosmetically, concerned about them as well. So the most common type would obviously be sunspots, solar lentigines. They're from UV damage because UV stimulates production of melanin, which is the pigment in your skin. And so when you get more sun exposure, you get more melanin production, and that results in these spots. They're kind of hard to get rid of. Lasers sometimes, topical sometimes. But the best thing is to wear your sun protection, and don't forget the more commonly forgotten areas like your hands and your scalp and your neck and your ears. Actinic purpura. I get this all the time. People are like, why am I bruising so easily? I don't understand it. I'm not on any blood thinners. Am I eating something? Is something happening? I don't know. Well, this is just a result of UV damage mostly, but also aging skin does thin. All the layers thin out as you get older. But UV, we saw in that photo the diagram where, UVA causes disruption in your collagen, your elastin, and when you don't have as much of that, then your skin will sag and the vessels become more obvious as you get thinner skin, and then vessels are closer to the top, so when you get minor injury, you get these. It's not dangerous, but it's hard to treat. Some people will take supplements like arnica like oral, or topical like bruise creams, and that can help accelerate resolution. Idiopathic guttate hypomelanosis. For always asking me, legs and arms, what are these little white spots I'm getting? And these are not just older people, these are younger people too. And it's more apparent when you're tan, because these spots don't tan that well, because it's basically sun damaging. It can damage your pigment as well as give it to you. But it's not dangerous, but if you don't want to have this, then lots of sunscreen and cover up. Poikiloderma savant. I just saw someone the other day with this. Most people don't ask about it, but other people are like, well, why do I have all this redness here? I don't understand. Is it like a rash or something? But you'll notice that it spares like right underneath the chin where like the neck is protected, and same thing with that, this one. And they're usually red and brown, and there's like some thinning of the skin. This is all due to sun damage. It's not dangerous though. If you want to try to get rid of it, sometimes you can use like something called broadband light, which is not a laser, but helps to address some of the reds and browns and destroys them. This person, it's not really a syndrome, but just something called it. It's just like these huge blackheads. And they're all clustered, and this is all due to solar damage. So all UV damage makes these big pores and blackheads. You'll often see this in somebody, but rarely do people actually ask about it. But thickening leathery skin on the back of a guy's neck, and that's just due to chronic sun damage. So when you get sun damage, your skin does try to protect itself in some way. So it thickens and it becomes kind of leathery. It's not dangerous, but it's a marker of a lot of sun exposure. And I found this, that was interesting, that 80% of sun damage occurs before the age of 18. So if you have any, children, grandchildren, start now, protect them now, because that's really the only way to start. It's not too late, after age of 18, but a lot of stuff really does occur before that. And you just don't see it until like you're 25 or 30, when the photo damage starts really, making itself apparent. So how can you protect your skin? Sunscreen. I preach that to all of my patients all the time, every day. I wear it whether I'm inside, outside. If I'm not even going out, I'll still wear it. And that's because you don't know when you're going out. Windows. I have my car windows tinted. I have, and tinting doesn't mean tinting, so I should explain that. Window film, because UV light is invisible. So it can be clear. If you want heat reduction, you get more of a tint, because that will block some of the heat. But the UV, film is actually just to filter out some of that UV, 99% of it. And I did that to my house too. It keeps the house cooler. Some protective clothing, so UPF rated clothing. I always wear like a sweater when I'm outside. It's lightweight that actually has UPF. Has like a little thumb hole thing too, because I've been more paranoid since I've gotten older about it. Broad brim hat every day. Umbrella, you know, if it's really hot, I mean, that definitely helps. I know they don't do that here. When I was in Hawaii, you know, there's no shame in using an umbrella. And especially during peak times, but it's there all the time. My daughter has a hat, and it like has these little design of like these flowers on the edge, and when there's UV light, it lights up purple. Even in the shade, it was purple. So, you know, it's not telling you how much there is, but it's still there. You don't think you're protected. You think you're protected, but things are like flying all over the place, you know, reflecting from the sand, the ground, just even in the air. Okay, so what does SPF mean? And I get the question all the time, is it really important to wear something more than SPF 30? I heard that there's, you know, no benefit to that. Well, you actually have to put on 1 full ounce to get the SPF that's on the bottle. That's 1 like shot glass full. That's a lot of sunscreen. So nobody does that. I mean, that's not normal. So I always tell people to go higher, because even though if you put on SPF really thick, you know, like cake frosting, you'd be fine. But nobody does that. So yeah, so you know, percentage-wise, there isn't a lot of absorption difference between like a 30 and 85, but if you're not putting on enough, you're gonna get reduction of it. And it's not like if you put on half, you get half of the SPF, you get a quarter. It's exponentially lower, okay? Water resistant, don't rely on this. You know, if you're gonna be in the water, reapply as soon as you get out, because these things aren't really that water resistant. You'll get some, but it's gonna come right off. Broad spectrum, meaning that it's UVB and UVA. Again, SPF usually refers to only UVB. If it says broad spectrum, that means there's some UVA protection. And generally speaking, you have your chemical sunscreen, avobenzone, oxybenzone. Those usually filter out both. But I'm really a fan of mineral sunscreens, zinc and titanium, because I think they, well, zinc covers more of a spectrum than any of them. It just tends to be wider, but you can get tinted versions, so it doesn't have to look so pasty. But there's been a lot of news out there about, like, you know, avobenzone, oxybenzone, like killing the coral reef or something like that. So if you're in the water and you're wearing it, you know, you might be killing some fish, maybe. But the zinc, you know, doesn't do that. It's diaper cream, right? So it's skin protectant. Just make sure you put on enough, just like we talked about. UV is invisible, so you can't see it. Don't rely on it. It's cloudy. Clouds don't filter out much UV. You know, maybe like an SPF of 3. That's it. Clothing will absorb or block UV rays, but not completely. Every piece of clothing is different. So an average white t-shirt's maybe an SPF of, or UPF of like 8. So it doesn't have to be thick. You just have to get like the right kind. So they do make a lot of brands like Coolabar, Solumbra, UV Skins that have UV protection factor rated clothing. But generally speaking, your polyester, synthetic fabrics tend to be a little bit more protective than, say, your cotton. And jeans, thicker weave, obviously more protective too. Okay, what about vitamin D? People are like, but I need a little vitamin D through my skin. No, you don't. You can get it through your diet. Not everybody makes the same amount of vitamin D anyway, so through their skin. There are people who are vitamin D deficient who live at the equator, and that's obviously a lot of sun exposure. Whether you're trying to get it or not, there will be incidental. So you can get it through your foods, or you can get it through a vitamin. Those are the recommended amounts. So seek shade, but remember, shade doesn't mean you're completely protected, so have your sunscreen on at the same time. Water, snow, and sand, they all reflect, and they actually can increase the penetration of the UV or make it more intense. So if you haven't noticed, you get more tan when you're in the water, so be careful about that. Don't go into tanning beds. It's the wrong kind of UV anyways, UVA mostly, and it doesn't give you any protective tan or anything, not that tans are protective necessarily. But use a self-tanning agent. It's just a lot more protective, but you have to wear sunscreen with it because those things don't have sunscreen in them. Okay? And then in conclusion, prevention is #1 thing that I can only emphasize, and you have to be protected, I mean, all the time. It's all cumulative, so some people are like, oh, it's just a few minutes. A few minutes over 20 years is a lot of time. So definitely wear it every day. Just use your moisturizer, put it by your sink, wash your face, and put it in your sunscreen. And then, as I said, UV tinted film for your windows in your car and home. You'll appreciate it when your furnishings don't turn like, you know, your carpet turns white or floor turns bleached, little stripes on it, because UV will do that. So if it's doing that to your furnishings, what is it doing to your skin? Okay, so some resources. American Academy of Dermatology is a really good one. If you, are ever looking for a dermatologist and you're moving away and you don't know who to see, if you go on that site and you put in your address, there's a little thing that says find a dermatologist. It'll bring up all the board-certified dermatologists in the area, and then you can pick who you want to see based on your location. We have 3 dermatologists over where we are right now. One of them is leaving, so we will have a male dermatologist as well. So. But yeah, so we're very convenient, located right across from the mall. All right, so that's it. And I'll open the floor for questions.
Dr. Kwan brought up a really important thing today. She was talking about exposure, and my father was a news broadcaster for 60 years, right? And of course, they didn't even think about sunscreen back in those days. And of all things that got sunburn were his eyes.
Cataracts.
And his, his eyes, well, I'm sorry.
It's more common on the left side of the face because of sun exposure.
Yeah, it was just so interesting. Just, they didn't even think about it. Sunglasses. Mm-hmm. Okay, so I was told dental x-rays expose you to radiation like time in the sun at the beach. Do you know about this?
Well, obviously radiation can cause higher risk for skin cancer, but I don't know that dental ones, I think you'd have to have a lot of dental x-rays to have a lot of risk for that, because those are really common. Radiation, clearly it's going to damage your skin, but I think they're very focal when they do it. I don't think it's a really high risk.
Okay. Is coconut oil good for sunburn prevention?
No, there's no UPF or SPF in any of that. No, I don't think so.
It just sounds good.
It just sounds good. Maybe it soothes the sunburn when you're done with it. Yeah.
What is the best thing to put if you come home from being out the day and you know that you've been burned? What is the best thing for immediate protection or care for your skin relief?
Well, not getting the sunburn to begin with, but I should mention. So there are some oral agents that people will use to boost the SPF kind of of their skin. Heliocare, astaxanthin, those are actually very common things that people will use as a supplement on top of their sunscreen. So if you're going to be out there a long time, that's something to consider.
Heliocare?
Heliocare is one item. Astaxanthin is another one. There's some other ones that are more generic. I think Heliocare used to be proprietary. Now it's it's generic now.
Okay,
it's over the counter.
So how would the audience find out what those products are?
You could just find them in a drugstore, actually. You could just find them at CVS. Okay. Heliocare. But in terms of treating a sunburn, it just depends on the degree of it. So if you have a blistering sunburn, I had a young woman come in with a blistering sunburn on her cheek, unfortunately. And I just, I told her, you gotta dry it out. You just use some soaks on it, dry out the blisters, and then usually a topical steroid of some sort will help. But moisturization, if it's just a minor, just a little redness, and you can just use Vaseline, gentle skincare. There's not a whole lot you can do for that.
Okay. What about aloe vera? Is that
it can be soothing, but I don't know if it's going to accelerate necessarily the
but just
resolution.
Soothing.
Yeah, it can be soothing.
Okay. Any downside to covering your body with sunscreen every day?
No.
Okay.
0.
Would you please repeat the clothes brands with protection?
Coolibar, Coolibar. Another one, it's a little more expensive. It's called Solumbra, Solumbra. UV Skins, so UV and then SKINZ. Those are really common brands. I actually own, I think, all of those items, actually. If you're an ultra athlete, I would go with the Solumbra. It's very lightweight, protective.
Okay, thank you. And then someone would like you to just briefly go over treatments for melanoma again.
Okay. So melanoma, usually that's by excision. So it depends on how thick it is. So they grade it on how deep it goes into the skin. If it is no penetrance into the dermis, then it's just 5 millimeter margins all the way around. So you actually have to take margins and then take the triangles and cut it out. If it's any deeper than, if it's between 0 and 1 millimeter, generally you take 1 centimeter margins. That's like pretty big. If it's like 2 centimeters, then you've got to actually sometimes take even 2 centimeter or 4 centimeter margins. If it's beyond 1 centimeter, or beyond 1 millimeter, you also consider doing sentinel lymph nodes, where people will actually see oncologists, and they'll like inject a dye and see if that dye, penetrates anywhere and lights up, and then they'll dissect those lymph nodes out. If it's very advanced and metastatic, there are a lot of agents out there, immunosuppressive stuff. Depends on which one it is that can be used. They usually see an oncologist, if they're on that stuff. So it depends on how thick it is. The ones we see generally in the office, we just cut out. If it's beyond like 2 millimeters, I send people to oncology.
Yeah. And it's never too late to check out a melanoma.
Never too late. I've seen ones that are really big, grow really fast. Like 100, actually she was like 100. She was a 100-year-old woman with this huge one. I was like, what is this? It was like weird. And it was, I think the Breslow depth was either like 3 or 4 millimeters. It was huge, and it was very weird because it only been there such a short time. I don't know that she succumbed to that spot, but she was very advanced in age, so she did pass away within like 6 months. Yeah, but I think they just cut it out.
Yeah.
Yeah.
Okay, so this person has to drive 20 to 30 minutes home from work every day, and is asking if they should apply sunscreen prior to leaving the office.
Yes, and put a window film on your window, front and side. I would definitely do that. That's the way to prevent yourself from getting wrinkly like the guy in the truck.
So window film.
Window film. Okay. I think it's more reliable because you're going to filter out 99% of that UV. It'll actually also protect, your dashboard as well, and any of if you have leather furnishings, it's not going to discolor anything, and it'll keep everything nicer, including your skin.
Yeah, that's wonderful, and it's legal. It's not
legal. It's clear. You don't have to get a tint. It's not tinted.
Okay, good.
Yeah. South Bay tinting. That's where my husband got his done. Yeah.
Oh, the dark.
Not dark. Clear.
Just clear tinting.
Yeah.
Okay, good. All right. Is there a connection between skin cancer and blood pressure medication?
Not that I know of. I don't think that blood pressure medication does cause any immunosuppression, so I don't think there's a relation to that.
Okay, thanks. Why do you consider keratosis in need of the cosmetic removal approach?
You're talking about precancerous spots or like
let's go with
benign spots?
Let's go with both. I would say that keratosis.
So actinic keratosis should be removed because they can potentially turn into a skin cancer, and those people have a higher risk because they often have many. Benign keratoses, usually we don't remove them unless they're symptomatic in some way. They're in somebody that, they're in their way of like combing their hair, or they knock it when they're doing something. You usually numb it up and shave it off. Cosmetic removal is for just cosmetic reasons. Our site usually charges $120 for every 12, and we usually freeze them or cauterize them, just because people don't like them. Which there's no, there's no shame in removing them for I just don't like them. It's just your insurance won't cover it. That's all.
Yeah. I think I have a lot of those right now. But they're not precancerous necessarily.
No,
they're just discoloration of your skin.
They're just discolorations. Sometimes they kind of look warty looking. So some people are like, "What are these?" And they're stuck-on looking, waxy, bumps, and they're brown or they can be white. Some people have like these stucco keratoses, like they literally like stucco on their ankles and their lower legs, and they wonder what is that. And I'm like, well, those are actually variants of the same thing. You'll also see some Asian skin types, Latinos, African American, like Morgan Freeman. He has those little things on his cheeks. Those are not moles. Those are actually variants of the barnacles, the seborrheic keratoses. And I do have a lot of people coming in saying, I have all these moles, it's genetic. I'm like, well, those are actually not moles, because we can actually destroy them with a cautery device and they can go away. But you can't do that with a real mole.
It's interesting he didn't do that. He's such a high-profile guy.
He doesn't care.
He didn't care.
He doesn't care, because they're benign.
And somebody has a question of where to buy the window film.
You usually have a professional, install it. I guess if you're really good, you can install. Oh, you mean like for a window, like your car or your house?
For the car?
The car?
Wait, you were talking about window film?
Oh yeah, window film. Like I would have a professional do it. So I had my house professionally done buy a mobile tinting, like just found someone on Yelp, and I just had them do it. I think it was like $1,500 to do a 4-bedroom, 2-bath house, all the windows, all of them. And I have also a little enclosure. Those have a lot of windows too, so it's actually a good size. Did it all in one day. For a car, I definitely would not do it because they're like little curves. It's very hard to get in those little areas. And then if you've ever done window foam, it requires a lot of squeegeeing. It's just too much work. You don't want to do it.
So it's better to
South
have
Bay tinting
actual
is a good one, but you could just Google somebody on like Yelp. That's the way I went for doing the film in my house.
Okay. So what drugs actually make a person as a higher candidate for skin cancer?
So somebody who's on immunosuppressive medication like cyclosporin, they're a transplant patient, they need to suppress their immunity so they don't reject their organ, like a kidney transplant, heart transplant. So if you're on those kind of medications for organ rejection prevention, you're high risk because those things also suppress your immune system, so you're unable to fight off the development of other skin cancers.
Okay.
Yeah.
There's a question here about zinc and titanium, and they do not harm life underwater.
They shouldn't. I mean, they're just minerals. They're inert. It's what we use on like babies for diaper cream.
So coral reefs and all
they
are
shouldn't.
protected?
It's just minerals. They're just minerals. They're found in the environment.
Okay. So we have a sailor in the audience, and he or she would like to know what's the best advice for their profession.
Serve your time, and if you're happy, stay in, but if you're not, leave. It's hard being in the military. It really isn't easy, especially as a woman, and it's a different lifestyle. There are some benefits, like you never have to worry about what's covered by your insurance because if you need it, you can get it. And that's one of the good things, but bureaucracy is very slow. And there's a lot of red tape when it comes to being, because there's like a whole hierarchy and people are often trying to promote, make rank, and they're going to make you look bad if it benefits their career. There are some really nice people, but some of the not nice people make your life hell. But yeah, I mean, it's a good way to not have debt. I have zero debt. I own nothing. And I probably made a little bit more money than my colleagues when they were in residency, but now that, the 4 years I was actually a dermatologist in the military, they were making more than me, but I have zero debt still, and they have more debt. So, yeah, only if you're happy. There are some people who career, they love it, they find it amazing, but if you don't love it, get out. Yeah.
Thank you for your service.
Yes, absolutely. Thank you for your service. It's our service men and women absolutely need good physicians as well. But if you're a sailor that wakes up tomorrow morning and you live here, what is your recommendation to that person?
I mean, if you can be stationed in this area, it's nice. If you're like somewhere in the middle of nowhere, it's not. If you're on a ship, I mean, when you're a junior, they make the junior sailors, if they're stationed on a ship, live on the ship, which is not fun. Yeah. Or in the barracks, which sometimes can be okay, but there's a lot of immaturity. There's just like a lot of young people. I just speaking from experience because, as a junior officer, I was like the senior female officer on a ship, and that was kind of weird. So, but you have a bunch of people right out of high school who don't really know where they're going. There's a lot of troublemakers. There's some nice people too, but there's a lot of stuff. Those people who are watching after them, they're like their mothers and fathers.
You're like a den mother, huh?
Yeah, but there's a lot of, it's just, I think because it's like this enclosed environment, it's hard sometimes because it's hard to get stuff done sometimes. And then, if you have somebody who's really out to get you, they can make your life really miserable. And it's really hard to fire someone in the military unless you're kill someone. Because it's also like civil service. If you don't document a history of someone, not doing their job, it's very hard to fire them. Very hard, extremely hard, beyond some kind of time frame. So once you actually get into the military and you're beyond that training part, very hard to get rid of somebody. There are people who are dysfunctional in the military who have to be in the military because they cannot function outside. That's the level of what we're talking about. So, but there's also some amazing people who do great things and they love what they do, and that's fine. But I think for me it's just harder because I was a doctor, and I was in the surface warfare like community, and they really didn't know what to do with me. And I had a senior chief who was like not nice and tried to make me look bad. And there's a lot of struggle. So,
Yeah,
but I always
sure.
tell people the military was the best worst mistake of my life because it led me to where I am today.
Yeah.
I'm a stronger person for it, and I got it. You know, I'm a dermatologist. That's not where I was headed towards. I thought I was going to be a pediatrician,
Yeah.
and then I found this, and it was so much better. But yeah, I mean, as I said, there are pluses and minuses. You never have to worry about your medical insurance. Everything will always be taken care of. You'll be well fed. You'll get what you need. But it's a prison, you know, in a way. In a way, because you know, they own you. They always make it a point to, you know, they own you. They do. You are U.S. government property.
Yeah.
That's basically what it is.
Well,
Yeah.
we are very grateful
Yeah.
for the time that you
Yeah.
you spent taking care of
Yeah.
all of the shipmen and also your future,
Yeah.
taking care of us. What do you think about chemo and steroids? Do they make you more sensitive to developing skin cancers?
Chemotherapy can. I mean, well, it depends on like how immunosuppressive it is. Yeah, I mean, it can definitely increase your risk. As for, what was the other? Oral steroids?
Steroids, yeah.
Oral steroids, yeah, I haven't heard so much about that. I mean, I don't know, a lot of people are on really like chronic steroids that would increase their risk. I think you would be more likely to get like diabetes and, you know, like a hump on your back and osteoporosis and cataracts and glaucoma than skin cancer from that.
Okay. Will the dermascan hurt your skin if you've been using topical cream? I think there was someone here that didn't want to do the dermascan because of that.
I don't actually know what the dermascan does, but I'm guessing it's just a scan, so it's just taking a photograph. So, no, I don't think so, but I'd have to research what the actual dermascan does.
Right. Okay. And then someone here in the audience would like to know how big keratosis cancer can get.
The biggest I've seen, well, in the U.S., they're usually not that big because people get them taken care of. But, you know, I'm sure there's some other countries where people don't think about what they are, and they're probably like really, really huge. But probably the biggest I've seen is, I don't know, maybe 2 centimeters. Not really that big.
2 centimeters. Okay.
Yeah.
Like that.
Yeah.
Okay, in terms of spots on your head and your shoulders and your face, how often should someone be checked with by a dermatologist?
No more than once a year if you haven't had skin cancer. If you've had skin cancer or you're very prone, you know, so we do skin checks usually once a year for people with skin cancer, but sometimes people come in more regularly to have focal things, you know, examined or treated, like the actinic keratosis, your precancers. So I have some people who can't tolerate, you know, doing any of the creams. They have so many. I just bring them back like every 2 months, and I'm like spray, 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 and we keep on doing it until it's much reduced. So it depends on the person.
Okay. This is an interesting question. So I'm 67 years old, and do I still need to stay out of the sun and be careful because it takes 20 years to develop a cancer?
That's actually not true. It doesn't take 20 years.
I like that one.
I've seen people develop, you know, a squamous cell on, there's a woman, top of her foot. She's like, why did this thing grow within like a month? She went to see someone else, and they're like, oh, that's just like a wart. And I looked at it, I'm like, I don't think so. So we shaved it off, and it was, you know, a squamous cell. I mean, it doesn't take 20 years for that to develop. Now, it takes 20 years for sun damage, maybe from the time you're a child to an adult to show up. But if you haven't noticed, like in myself, I've even noticed, you know, as soon as I hit like my late 30s and now I'm 40, you know, things are just like popping up, just like, where'd this come from, you know? So it's, and also having babies does that
If you were
too.
inside for 67 years, then.
Yeah, I mean, it's never too late to protect, because you can always get, I mean, there are some people who don't develop a skin cancer until they're 80, but you don't want that. I mean, and nobody likes looking old, and people who are older, they often come and say, you know, is it vain for me to be worried about this wrinkle? And no, of course it's not. I mean, it's just what you prefer. So if you want to be, you know, continually exposed, even at age 67, people are living so long. I mean, you could definitely develop leathery skin, you know, within like, it doesn't take much.
And you're right. It's just it's quiet until it decides to rear its head.
Exactly.
I certainly know people in their early 70s who developed squamous cell, and my dad, in his 80s. I mean, it's there, but it takes a while sometimes. So, what hypoallergenic sun protection lotions would you recommend?
You know, there's a new one called Sheer Zinc by Neutrogena. It's actually really nice and it's easy to find. It's a SPF 50 and it's more lightweight, so it's not as goopy as some of the other ones. If you have very sensitive skin, there's also something called Coats, C-O-T-Z. That's also available like in the stores, but I usually look for it online because it's easier to kind of find. There's C-O-T-Z. Yeah, so that's a really nice one. It's very elegant. A lot of women like it because
I've used that before.
Yeah. There's also
nice.
Ulta MD, but those are sold through doctor's offices, although technically you can find online too. That's very, very sheer. People love it because it just glides on.
Yeah, you don't feel it.
Yeah, you don't feel it. It's not
Zinc
goopy.
all over you.
Yeah. The Sheer Zinc, it's sheer, like sheer, S-H-E-E-R, and then Z-I-N-C. You can find it in the store. It's usually in a kind of yellow to white, little container, and it says Sheer Zinc on it, and it's 21% zinc. So you just look at the back to confirm it, but it's mineral sunscreen only. There's nothing else in it. Sometimes you'll find a mineral sunscreen that they sneak a little bit of a chemical sunscreen into it to boost the SPF, like octinate or something like octosalate or something like that. Those aren't usually the ones that people worry about, damaging the coral reef. That's more like avobenzone and oxybenzone. But yeah.
What protection for the lips do you recommend? Because it's a sensitive part.
Sensitive areas. So I actually just when I put my sunscreen on, take the back of my hand, I just wipe some of it on my lip. But you can actually, the Coats, C-O-T-Z, they actually make a mineral sunscreen for the lip. Yeah. And then Ulta MD also makes a sunscreen for the lip. And if you just go on Amazon, you can find completely zinc titanium sunscreens that are for the lip. But if you just find like a chapstick with SPF, it's probably gonna have avobenzone on it or oxybenzone.
And that's not good.
I generally don't like eating it, so yeah, I don't think it's a good idea. But I mean, if you're just putting it on the outside and you're not getting it really close, it's probably okay. I'm sure there are many a person who has swallowed it and it's still okay.
And they're still
they're still alive,
breathing.
Yeah.
Okay, so a sunscreen was purchased a couple of years ago. And how long would you say that you would trust it efficacy even if the expiration date is?
So it depends on whether it's a mineral sunscreen or it's a chemical sunscreen.
I'm sorry, a mineral or a?
Chemical sunscreen.
Chemical,
so
okay.
Zinc oxide is just zinc oxide. I don't think it ever really expires. Now, I always wonder myself because I've asked, the people at Ulta MD, I'm like, is this really expired? It has an expiration date because it is considered, an active ingredient. So it has to have an expiration date. It doesn't mean there's anything bad about it. Now, if it smells like funny or it's running, there may be something else in it, like a preservative, that isn't good for you to use. So, as long as it still has the same texture and it's zinc or titanium, I would still trust it. Beyond that, like avobenzone, I mean, probably within the first year, you can probably still use it. It's not that it necessarily becomes completely ineffective, but I don't really know how the chemical sunscreens might change, over time, especially if it's exposed to light or heat or stuff like that. But we all know that, zinc is going to be zinc. It's diaper cream. It doesn't really change. It's only if there's something in it that is making it, not grow like fungus or something in it that I'd be more worried about.
Okay, good. This question is about the SPF and 50. You had said 35 to 50. That's kind of like the max. Beyond that, this individual asked if 110 is too much.
No. Actually, there's a recent paper that was published that shows that higher SPFs are more protective because people will put on, as I said, not as much when it's lower. But there used to be a myth that, it's not protective, but now they've actually shown that it is, that they expose people to UV based on how much SPF that they had worn, and the people who were wearing the higher SPF actually had less of a reaction, like redness, to sun exposure. But again, remember, it's exponentially lower. Nobody puts it on as thick as like a quarter on your face. Come on, nobody does that. And you don't think it's a lot, but once you start rubbing it in, you're like, what is this?
You need more face for all that cream.
I mean, the only way to really do that is if you use one of those really sheer ones, and then you won't notice it. You just layer it, let it dry, layer it, let it dry, and do it a few times.
Okay.
Yeah.
This is an interesting question. How likely is a squamous cell carcinoma to become an invasive melanoma?
Squamous cells never turn into melanoma because they're completely different mechanisms. Melanoma are funny, you know, melanocytes. Actually, melanocytes that have become deranged and grow funny and have, you know, strange nuclei. A squamous cell is called a squamous cell because it derives from the squamous layer of the skin. So it's from your epidermis, and it kind of goes deeper in. So they're not melanocytes, they're keratinocytes. They're different cells. They're completely different.
Yeah. Completely unrelated.
Yeah, so melanocytes, you know, for melanoma, keratinocytes, your skin cells for your squamous cell.
Okay. Is in terms of family genetics and family history, would you say that melanoma is the only one that tends to run in families?
I would say that for basal cell and squamous cell, usually people who have them do have some family history because people who live together play together, so they have the same habits, they do the same stuff. And they have fair skin or they have the same risk factors. Right. There are some weird, you know, I mean, there's some weird syndromes where people are more susceptible to basal cell, but those are not that common. Melanoma, when you're young, if you get it when you're young, it tends to be more genetic. When you're old, it's usually due to like chronic sun damage.
Okay. So we're going to open up the floor if anybody else has questions. I actually just wanted to ask Dr. Kwan, as an oncology nurse of so many years, why are we seeing so many more cancers? Is it an awareness issue? Is it because there is more time that we're out in the sun?
I think that people spend more time in the sun these days. You know, as I said, like back in like the 1900s, like early, people are always about protect, protect, protect. They didn't want, I mean, they used like, you know, lemon to bleach their freckles. They didn't want to have a tan. Then, you know, Coco Chanel came out and had like a glorious tan and everyone
where did that all start?
The 50s, 60s. And then people stopped wearing hats.
Copper tone.
Yeah, you know, you ever see like Back to the Future when he goes back to like the 1800s and he doesn't have his hat and his grandfather or great whatever, it's like, you don't have your hat? That's like not having, you know, like, where's your hat? Yeah. You know, people, these days, like half the population doesn't wear one. Although I have seen people, you know, more often wear one, and even people who are jogging wear the full-on, you know, hat with the drape and everything, which I think is pretty impressive. They should be doing that. But
right,
yeah, I think it's habit.
Curious, on your presentation, you said something about microwaves and different things. Right in this room here, there's got to be people with smartphones and telephones and TVs. There's got to be billions of these rays going.
So, you know, there isn't necessarily any correlation that they can prove of other things other than UV causing like a risk for skin cancer. But certainly, you know, I think I read once that, you know, people who work around a lot of heat, who, you know, maybe like fire, that kind of stuff, like, or welding stuff, sometimes they do have a higher risk of certain kinds of skin cancer, I think, because areas of damage. So areas of chronic damage, scars can be higher risk for skin cancer. And that's just a phenomenon, I think, because those cells in the skin are different and they're not the same. So they're a little bit more susceptible to potentially, you know, getting a skin cancer in them. So, I have seen, you know, I have seen people with burn wounds or like huge scars that you know, eventually develop a skin cancer. It doesn't happen a lot, but it does happen.
Well, you know, the electricity, the flux,
Yeah.
the power lines, and all these
Yeah.
things. It just seems to me like you're
Well,
asking the question, why so many more skin cancers? Well, we've got a heck of a lot of stuff.
there's carcinogens everywhere. I mean, like breathing the air is a carcinogen. So smoke is a carcinogen. Those all can, you know, damage your skin. But the only thing we know, like proven, like actual one, you know, correlation is UV, you know, damage, because of how the UV actually can penetrate into the skin. And it makes sense because, you know, you have your UVB going in primarily top layer, and your basal cell and squamous cell, those are mostly epidermal top layer type of skin cancers. I mean, they can push into the dermis, but you don't have anything, you know, that's like called a, you know, collagenoma or like as a skin cancer. They're all like superficial. They're up at the top. Melanoma is the only one where the melanocytes can actually start traveling into the dermis more and become more invasive. But those are all like, it's pretty much UV. I think the microwaves and infrared, those are very minor. In fact, people will often use infrared for other things like that actually help the skin. So, and UV itself, I mean, people do use UV in some cases for like other conditions like eczema, psoriasis. So it does have some benefits because it is immunosuppressive. but it's not something I would do unless you absolutely had to. You know, some people go into light box UVB, which is very controlled wavelength, not like the whole broad spectrum. For people who have like, you know, like a generalized guttate psoriasis or maybe like chronic hand eczema that doesn't respond to anything, you know, some people do go into UV therapy for that.
So does it, okay, great. You have a question?
Should I avoid golfing, which is like 5 hours in the sun, after having a history of squamous cell cancer?
Not that you can't, I mean, it's not that you can't do your normal things, but you should be protected when you do them. I might suggest doing it earlier in the morning or later in the evening, wearing sun sleeves, like golfer sleeves that have the hand, you know, and then like a good hat that has the drape for your neck as well, and then lots of sunscreen. Just don't go out at noon and do it, because that's really the worst time. And if you ever like Google like UV index, it's like very shocking, you know, California, what that index is. It's very, very high, and it doesn't even have to be cloudy for that to happen. So it's not like you can't do your normal, as I said, you can't hide in a cave, you can't like live like you don't have any life, but just don't do it during those peak hours, wear your sun protection, and I think you'll be okay.
So the areas that are exposed, so arms and face and chest.
Exactly. I mean, as I said, it's hard to hide your face completely, but you can wear your sun protection, you can reapply, you can wear the hats that have the drapes on the side so you're more protected. And then, you know, if you're on the golf course, carrying an umbrella, I mean, I'm sure you have a golf caddy that carries your umbrella and your other stuff for you, right?
Because that would look really good on the golf course.
No, people,
the umbrella.
I have seen people with, I mean, like you'll see those.
I'm kidding. They are.
Yeah.
I mean, it's probably going to start happening where people will start wearing hats with protection. They do.
Yeah, and it helps against heat. It gets very hot on a golf course, you know.
Yes. Yeah, very hot.
But just protect those kids, because, you know, I do have a lot of parents that come in and there's still a struggle about applying sunscreen on the children. And, you know, it's unfortunate because all those kids in 20 years will be like, but why, you know, why did they force me to do it? You know, so you just got to really work on that part. That's where you need to like start.
Right. Back in the 60s and 70s,
Baby
when we
oil
were sunburned, my mom
yeah.
would say, just jump back in the ocean. There was like nothing to just deal with it.
I hear all the time, burn, 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 burn as much as you can, and then you won't burn anymore.
Right, right. Does anybody else have another question? Yeah.
I wasn't sure about the dermis scan after hospital radiation for really aggressive sinus.
Okay. I mean, I don't know what the dermis scan is based on. Is there any UV, like how does it scan? I don't really know. We don't use that in the office, unless, Katie, you know it.
Katie, do you have that? Okay, they're not here anymore.
Yeah, I'm not sure what's actually in the dermis scan. I had to research that. I mean, I don't think it has any radiation. I mean, I wouldn't think that.
No.
And then, who's been in it? Did it have any kind of weird, like black light? It might be a UVB light, like a black light. So it's probably very minimal. I don't know that you're only probably in there for like a really short period of time. Yeah, so I don't think if it's just a black light, I wouldn't stand in it for like an hour, but yeah, that black light is UVB though, just to let you know. So that's how it gets highlighted. I don't think it's going to be something that you should worry about if it's only a few minutes. As I said, UVB focus sometimes is used for treatment of other things.
I noticed I don't put sun lotion on my face, but I walk in the morning. When I come home, under the eye, all this pocket is white. The rest of the face took some sun.
Yes.
But those are white. And
did you have sunglasses on?
No. And those pictures taken shows that it's very white. What happens there?
You never wear sunglasses at all?
Seldom.
And no other glasses?
There's circulation, don't you think?
I don't know. I'm not sure why that would be. There's a lot of people who wear, you know,
the machine, that we talk about the machine.
Yeah.
That was totally purple, and I didn't use any lotion with protection today. And she said it's sunscreen. I can't do that. So I was with the machine reacted on the light. The same portion which the skin outside was a sunscreen.
So she said it was purple because you had sunscreen on?
Yeah.
It could be a lotion. It could be some other lotion, a moisturizer. It could be anything on your skin that you put. I'm guessing it kind of picks up some like creams.
Some reflection, yeah.
Yes.
So I understand, like, if you're out on the water, you're getting a double dose of sun.
Oh, yeah.
It's also reflecting off the water. But how does it affect when you're actually in the water?
In the water, so, you know, I think back to physics, and you know how like the rays go in and it actually increases the angle of penetration. So that's why people usually get more burned and tan in the water. So it's actually worse in the water than outside the water. So definitely wear on your full body rash guard.
So the rash guard is a really good idea, even better than sunscreen.
It's better. People can on occasion burn through their UPF rated clothing if you're out there for like 5 or 6 hours. But I'm guessing most people aren't out there that long. So.
But for divers, you're right, and surfers and swimmers,
Full body suit.
Does anybody have any thoughts or questions about something we didn't cover? Well, it's just been wonderful to have you here. Thank you for joining us tonight, and you know, enjoy your summer. Got to run to REI and get all that new cover up, right?
Yeah.
Some good hats and clothing. Thank you all. We'll see you soon.